Hello, everyone. Today, I want to talk about the common conditions that we use platelet-rich plasma or PRP in our clinic at Essential Sports and Spine Solutions. I think this video will be useful for those individuals that have interest in PRP and want to know if it'll work for them and whatever ailments they're dealing with. A lot of what we do based in our practice is strictly from the evidence that's put out before us. The godfathers of the industry have been putting out study after study for many years, and we're trying to mimic and follow their guidelines as closely as possible, and also trying to establish our own new guidelines and making more studies and more data that's going to be accessible for people down the road. I think the low-hanging fruit, the place that we should start off with is knee arthritis. Osteoarthritis of the knee, obviously very common condition, especially as we get older. We develop arthritis in different joints, and sometimes that arthritis can become debilitating. So there's pretty good evidence thus far of showing PRP for mild to moderate knee arthritis. Usually when it gets to severe stage, then just a regular platelet-rich plasma injection is probably not going to help very much. And that's something that I'm pretty upfront with my patients about. That's something you'd have to discuss with a practitioner that understands the degrees of arthritis in the knee. One thing that we do in our clinic that might be different than some other places, though, is how we approach the knee and knee arthritis. So quite frequently, especially in certain clinics that don't have physicians and are using nurse practitioners as the injectors, places aren't using image guidance. And we know that we can significantly increase our injection into the target site by using ultrasound and or fluoroscopy, usually a combination of both. Something like knee arthritis, the injection with ultrasound is pretty reliable, and the approach can vary. Sometimes we come from the super patellar approach, super up patellar approach. Sometimes we come to inferior or lateral inferior approach. And I think it does matter. And I think that's why using the approach that's been introduced with us with the ultrasound to the super patellar approach is the most reliable. But what other people might miss and other practices might miss is injecting into some of the supporting ligaments, such as the LCL, the medial collateral ligament, or the lateral collateral ligament. There are even some physicians that will be injecting into the ACL and PCL. And again, those are structural issues that might be affecting the knee. Sometimes, you want to inject into the meniscus if there's some significant damage, or sometimes around the meniscus. There's also different tendons that attach to and around the knee, such as the hamstring tendons and the pes anseri bursa. These are all structures that need to be taken into account when you are doing a good knee platelet-rich plasma injection. The next, probably most common thing that we see in our clinic is shoulder pathology. Now, this can be for rotator cuff tendonitis, tendinopathy, tendinosis. Some of these terms are run synonymously, but they aren't actually that close together based off of the pathophysiology that we see. Biceps tendonitis, acromion-clavicular joint arthritis, all these things, glenohumeral joint arthritis, all these are conditions that we treat with PRP for the shoulder. So similarly to the knee, where you might see some of these structures be injected blindly at some clinics, again, we use ultrasound guidance and or fluoroscopy x-ray guidance to make sure that we're in the proper site and we're getting the medication, the treatment to the proper area. For general rotator cuff pathology, there's a protocol that we use that's a glenohumeral joint injection, as well as injection into any of the tendons that might be affected, and then as well as an injection into the subacromial deltoid bursa. And this seems to be the approach that's being studied pretty heavily right now. And that's kind of the approach that we're starting to take. And we're seeing much better results than just a basic glenohumeral joint injection or the subacromial deltoid bursal injection. So that's something to keep in mind. If we see some pathology in the tendons, say the supraspinatus, which is most common, or one of the other rotator cuff muscles, then we try to inject some of the PRP into the deficits into those tendons as well, and that can also show to be beneficial. Similarly, if there's acromioclavicular joint arthritis, we inject there, or if the biceps tendon has some inflammation around it, then we want to make sure that we get around the biceps tendon. It's not really a tendon that we inject into because it's a pretty big load-bearing tendon and potentially could lead to increased risk of rupture if we were to inject into that. So we try to inject around the area. I'm going to pause here and just put in a little caveat, like this is what I practice here in 2025. We're late 2025. These protocols might change in the next 5 years. And as we can continue to get more patients in the database and more data and more studies, then we may realize, hey, there's a better way to do this, or there's another approach that we want to try. I'm trying to use the best base evidence that we have now. And I think this is what differentiates a lot of practices that do PRP on the side to make extra money versus people that have a passion for this and are considered regenerative medicine experts. That is probably one of the biggest things people should be looking out for when they are going to get these procedures done. Again, some things to look for are these physicians trained in one of the subspecialties that would cater to regenerative medicine. My training, physical medicine and rehabilitation, orthopedic surgeons, sports medicine doctors. These are the type of doctors that have more training in the musculoskeletal health system. Now, you could go to some other physicians, but do they have that actual extra training to do it? Are they experts in the musculoskeletal health and musculoskeletal anatomy? That's going to be a very important question. Or are they just doing blind injections? Again, that's one big thing. And that'll take me to the next point is, are they just doing blind injections? I would be very hesitant to send anyone to a practice that does non-image guidance procedures. Not only because we increase the accuracy of where we inject the substances, the platelet-rich plasma or whatever we're injecting, but also what if there's other structures that you want to look for? And that might be those ligaments and the surrounding tendons and tissue. You wouldn't be able to see those or be able to actually palpate those and inject appropriately. So that's why using image guidance is the gold standard, should be paramount, and the only physicians and practitioners you should see are the ones that are using image guidance. Another one is, have they been doing this for several years, treating hundreds, if not thousands of patients? Have they been studying the literature? Have they been up to date with the literature? Are they going to conferences? Again, it's very easy for people to offer this, hey, PRP for X amount of dollars in our office, because it's the fancy buzzword. But you should really be looking for people that are passionate about this and are leading the industry in what the best protocols are. And I think that should be a sharp line of demarcation of who to trust and who not to trust. Not saying that these other physicians are untrustworthy, but we know that the more training you have, the more skills you have, and the more skills you have, the better outcomes we're going to get. And I think that also will lead to the point of, it's easy to have a PRP centrifuge in your clinic. There are reps for hundreds of companies that come to my office every year and say, hey, I have this PRP kit. It's much cheaper. It does X, Y, and Z. You only need a single spin. You don't need a lot of blood. And all these things have been proven to decrease the yield of platelets, and potentially, and what we're really exploring right now, is those less platelets typically lead to less results. So if you only get a small amount of blood and you do a single spin system, because the rep is someone you like or the kit was cheap and you charge it 5, 6, 7 times what it should be, then you're going to get bad results. And that's something else you should look out for. Then you should question your practitioners. What kind of kits are you using? Are you using one of the industry standards? Following that, I think another thing to consider is, are they a part of a national database like Data Biologics? Are they putting in their patient information, and are they tracking their patient outcomes? And is it contributing to the field as an advancement, or are these individuals just doing it so they can make more money and not want to contribute to the field as a whole and have better outcomes in the long run? And now I'm not trying to say that people are greedy and they just do it for the money. I think a lot of these practices are well intended, that they want to help their patients, but they don't have the nuance and the details of how a good platelet-rich plasma treatment should go. And then the final thing is your practitioner explaining to you what optimization of your body is. And that might look like making sure that your metabolic activity is stabilized. That's including thyroid and hemoglobin A1C. Is your sleep up to date? Are you having any active infections? Have you been on steroids recently? Are you taking non-steroidal anti-inflammatory medications? What is your stress level like? What is your exercise tolerance like? Are you able to increase your exercise tolerance around in the procedure time before the procedure comes up? Are you optimizing with the proper nutrition and supplements? Are you avoiding alcohol and tobacco and nicotine and THC and other recreational drugs? All of these things are important, and they shouldn't be swept under the rug with a general platelet-rich plasma treatment. Even the baseline, we need to be talking about these things, and we need to make sure our patients are optimized to get the optimal results at the end of the day. So shifting back gears into the other common injuries that we use to treat PRP in our clinic, tennis elbow and golfer's elbow. Your tennis elbow will be on the outside part of your elbow, golfer's elbow will be on the inside part. Quite frequently, we do this. Again, very important to do under ultrasound guidance to see where the tears and tendinosis and tendinitis might be. In our practice, we use the technique where we fenestrate, and actually we will use the needle to make a little more holes and then fill those gaps as well with the PRP. And this potentially can help with the healing process and making newer and stronger tendons in the area. There are studies to show that just doing the fenestration show the same outcomes for pain, but we don't know necessarily for function overall, and if there's actual tissue regeneration with just the fenestration. So that's something to keep in mind. The reason we do this is because there's something to talk to me. Now, again, this might be something that changes for my practice and myself in the next 5 years if more of these studies come out. When I was doing the research for this, there's only a couple studies that actually showed the difference between actually using that fenestration technique with the PRP and not. The next most common that we use in our practice will probably be, and I'm going to lump this together, facet joint injections, whether that be facet joint injections in the neck or the lumbar spine, specifically after motor vehicle accidents. Quite frequently, people will have these issues, or just chronic arthritis from wear and tear from the facet joints in the lumbar spine or the cervical spine. Very, very effective. Even after one treatment, after a few days, patients are like coming back saying, man, I have great results with that kind of treatment. And then the final thing that we use in our practice, and again, there's plenty more, is intradiscal treatments in the intradiscal into the lumbar spine. This isn't something we jump to right away, because typically what we do is we treat the functional spinal unit. The functional spinal unit means the vertebrae, the disc, the vertebrae, the epidural space, the facet joints, and all the surrounding ligaments, such as the intraspinous ligament, the supraspinous ligament, maybe the intertransverse ligaments, maybe some of the ligaments that attach the lumbar spine to the sacrum. So these are all treatment areas, and we try to treat the functional spinal unit as a whole. And sometimes that's all we need to do, and patients do great. But quite frequently, patients have had these kind of treatments in the past and are coming to us for the training for intradiscal injections. Now, there's a lot of controversy around intradiscal because of the increased risk of infection into the discs when we inject it for specifically degenerative disc disease. The risk is that we potentially increase the risk of infection. It causes discitis, which is a nasty, terrible condition. Don't wish it on your worst enemy kind of thing. And it can also potentially degenerate that disc more. Now, the study that showed that it degenerated the disc more was based on healthy discs that were injected in animal studies. We don't know what happens to discs that are already degenerated. And what we also, that study that showed was with steroids. What we're doing is injecting an orthobiologic, and that orthobiologic may, in fact, heal that disc a little bit, and it won't lead to faster degeneration. Now, some of those other areas in that spinal area is the epidural space, some of those ligaments I talked about in the spine, some of the fascial tissue, and some of the muscular tissue, or other treatment sites that we treat in the spine. We use fluoroscopy guidance mainly for the spine procedures. Ultrasound can be useful, but what we can't see is the clear delineation of if we go intravascularly. So we try not to do any of our spine procedures with just ultrasound, and we do want to use our X-ray and fluoroscopy guided approaches. There are other conditions that we can use PRP for, just not something that we use commonly in our practice. Ankle arthritis, first CMC joint, that would be this thumb joint arthritis, carpal tunnel syndrome, ulnar nerve compression at the elbow, joint arthritis in the fingers and hands and toes, plantar fasciitis. These are just not common conditions that we use in our practice because a lot of the patients that come to us aren't those candidates, but we do it for the symptoms the conditions that were discussed in this video. And yeah, that's kind of what we use in our practice. I hope you found this useful. Please share it with anyone that you might think will benefit from this kind of information. And if you have questions, feel free to drop them in the comment section below. Don't forget to hit the subscribe button. And if you want to work with us, just look us up on our website, essentialsportspine.com, and you can request an appointment. And I look forward to talking to you soon. Take care. Bye.